Dear friends, dear ESSKA community, it is an honor for me to present our ESA consensus on AC joint dislocations. It was a lot of work together with my co-authors, and I'm just the one who's presenting it, but the real work has been done by the other guys. We published it in our journal in CASTA last year, and it's open access so everyone can read it, and it gives you an insight also if you're not a shoulder surgeon how to treat AC joint instabilities, and it gives you like a guideline which is quite interesting also for knee surgeons. These are my disclosures. I would like to thank all surgeons involved, which were quite a lot, and they are all experts in their field, and thank you to those as well. Well, what do we currently know? We know about the Rockwood classification, about the different stages, 1 to 6, and then there are also some other classifications out there like the Bannister classification or the Tossi classification. The Rockwood classification basically tells us if the CC ligaments and the AC joint capsule are ruptured or not, and how much they're ruptured. Grade 6, interestingly, it was never seen except of one surgeon who told me he saw it in a multi-injured patient, but otherwise we see 1 to 5. Additionally, the ESSKA statement differentiated grade 3 Rockwood AC joint dislocations into 3A and B after 3 weeks. So after 3 weeks, the patient is examined again, and we first have in the 3A a stable AC joint without overriding of the clavicle in the crossbody adduction. So if you move your arm horizontally to the other part, the clavicle does not override over the acromion, and we do not see any scapular dysfunction. Grade 3B, after 3 weeks, shows an unstable AC joint with overriding of the clavicle over the acromion, and we have therapy-resistant scapular dysfunction. So, do those need an operation? Then we have different radiographic measurements, the GACA angle, which is a very interesting approach to quantify dynamically the AC joint instability, or we have the AC-DC distance trying to do the same, and these are just some radiographic measurements out there. And then also we don't know what is an acute and what is a chronic AC joint dislocation. Is it 6 weeks or 3 weeks? We're still not consenting on this one. And there are over 160 operations of treating AC joint dislocations. So we have a tendon or a suture wrapped around the coracoid, or we have weaver done, we have arthroscopic or open double button techniques, or dog bone button techniques, or however you would like to name them. And then we have the well-known hook plate. What do we know about postoperative rehabilitation? Do we need a sling, an abduction brace? When do we start range of motion? How much range of motion? How much weight bearing? And when shall we start weight bearing? Well, we wanted to answer all these questions as good as possible, so that's why we did a Delphi assessment. We used the currently modified variant from RAND and UCLA. So basically we have different rounds, and the first round is really an open-ended questionnaire where we looked at the current literature. So we looked at all publications since 1960 until that date, that was in 2018. And then we asked the audience what the questions are, what the topics are that we want to answer. And then the second round was a review of the summarized, the summary of the first round, and the goals were to find the areas of agreement and disagreement. And then the real consensus started, so we asked the questions, and then we saw how many surgeons agreed to one statement or the other, or if they disagreed. And then, in the end, it's a funnel-shaped issue, so we start with a lot of questions and we get down to less and less questions. So this might have up to 10 rounds. And over 66.6% is considered a consensus. This is our Delphi process. So as I said, 2018, we started with the ESSKA closed meeting in Athens, gathering all the questions, and we presented all the current literature that was out there. Round 2 was an online questionnaire with also the possibility to submit new questions. Then round 3 and 4 were online questionnaires with the condensation, as I said before. And then round 5 was our final consensus meeting at Specialty Days in Madrid 2019, also discussing the outcomes and what we found is a consensus or not. And then in the end, now we published it in KStar, and you will see it at the ESSKA conference, hopefully. So these are some insights on how many AC joints we treat. This is not operative, just treating. So most of us treat about 10 to 50 a year. Rarely we see above 50, and above 80 it was just one person. And these are the operated AC joint dislocations, so all of us operate less than 30 a year, but this is just operative treatment, not conservative treatment. This is to give you an insight how it looked like. So this was a question answered. I consider a case if it is. So less than 1 week, less than 2 weeks, less than 3 weeks. These were the possible answers. And these are the round 2, round 3, and round 4. So you see how the weight was. Round 2, less than 2 weeks was like 39.3%, and then it changed slightly at round 3 and 4. So this is how we developed a consensus, and in the end we considered a case acute if it was less than 3 weeks. At round 4 we were at 66.7% of consensus, which we defined as a consensus and which is generally defined as a consensus. So here I present you the results as a basic workup. So what do you need? Radiographs, you need a clinical test, and you need to assess horizontal instability. With radiographs, a true AP is enough with a panoramic view without weights. So we know that a lot we used weights, 10 to 5 kilos in axial loading. You don't need this. And we don't recommend any additional imaging like CT or MRI or sonography. Then in clinical tests, we test for scapular dyskinesia and especially for horizontal override in the cross-body test. This is very important. Check for horizontal override. Then, of course, we check for pain, and we don't recommend the AP test because it doesn't give you enough information. Then, for horizontal instability, check the horizontal override. There are no specific radiographs that we recommend. There are, but we don't recommend them, and not recommended is MRI, CT, sonography, or panoramic views for horizontal instability. What is not recommended is measuring the AC joint width because it's not reliable enough. We do not recommend measuring the AC-DC or DC-PC or the modified Alexander view. Of course, you can do them, but it's not recommended to do this. What do we find regarding chronicity? We agreed that, as I said before, less than 3 weeks is considered acute, and over 6 weeks is considered chronic. So there is a little gap in between, which is 3 to 6 weeks, which we consider as a subacute stage. So regarding the classification, we agreed that the Rockwood and ESSKA's classifications are enough, especially with adding the 3B. And these are comprehensive enough, and most of us, we know it already. What we do not recommend is the Bannister classification or the TOSI classification, because they're not comprehensive enough and they don't guide our treatment. Then, how do we treat our patients? First of all, we found a consensus on conservative treatment. Immobilization in a simple sling for 3 weeks. Then we start full range of motion, which should be after 6 weeks. Weight bearing is started after 6 weeks, so at week 7 to 8. And then we have week 10 to 12, which is the minimum time considered until failed. So if the patient doesn't get better at this time, we consider a patient that the AC joint injury rehabilitation has failed. At week 12, over 12 weeks, return to full overhead activities, and contact sports are only allowed after 3 to 4 months. When do we switch from conservative to operative treatment? Persistent pain is our consent. If the patient has consistent pain, we switch from conservative treatment to operative treatment. And what kind of treatment? I will present it in the next slide. We did not consent on horizontal override to switch from conservative to operative treatment on the Rockwood grade or just discomfort. What do we choose as operative treatment? So this is the overview. So we have the acute stage and the chronic. On the left side, you can see the consensus on acute, and on the right side on chronic injuries. So, as I said, less than 3 weeks is considered acute, more than 6 weeks is considered chronic. We have a subacute stage which is 4 to 5 weeks. What do? We use a suspensory device, arthroscopically assisted, however you like to name it, and you need to address the AC joint capsule because we have a lot of literature and evidence out there that the capsule gives stability on the AC joint, of course, and also for horizontal stability. We don't do or recommend routine AC joint resection. When do you use a tendon? For the chronic operative treatments, you need a tendon. So tendon augmentation is recommended. We use a semi-T tendon wrapped around the coracoid. And for the acute treatment, there is no graft augmentation necessary. How is the postoperative treatment? This is almost the same as the conservative treatment. So patients are immobilized for 3 to 6 weeks in a simple sling, no active range of motion, only passive. At 6 weeks, full range of motion is started, and pain is considered as a criteria for full return to activity. Weight bearing after 7 to 12 weeks, and return to full overhead activities over 12 weeks as the conservative treatment. Pain is considered as a criterion other than time. So we don't only stick to the time criteria, but also to pain. If a patient is getting better with pain, you can start earlier with the weight bearing. If a patient has more pain, you will have longer rehabilitation. And also here, full contact sports and full weight bearing is only allowed at 3 to 4 months. I hope I could give our ESSKA audience a little insight into how to treat AC joint instabilities. If you have any questions, contact us or any of the ESSA board members. And I would like to thank you for your kind attention. Our communication office is really active on Facebook, so follow them, and thank you very much for your time and for your attention.